Welcome to the Deep Dive. Today we're tackling a really important area of healthcare, the principles and standards behind accreditation.
That's right. We'll be focusing specifically on the international guidelines from ISQA and also the national standards set by NABH here for both care homes and hospitals.
Our aim in this deep dive really is to give you a solid grasp of what healthcare accreditation is all about.
Yeah, highlighting its impact on quality, safety, and how it puts patients right at the center of care.
Exactly. And we've sifted through quite a bit of information to bring this to you.
We certainly have.
That includes ISQA's own guidelines and principles for the development of health and social care standards, the NABH accreditation standards for care homes.
And their latest hospital standards, too, the 6th edition, which just came out in January 2025.
We've also looked at some practical perspectives, things from Supremediq consultancy, V-Comply on policies.
And a really detailed look at Alameda Health System's real-world policies. I mean, everything from emergency response, medication handling.
Even how resident doctors are supervised. It's quite comprehensive.
And to give you the complete picture, we've also drawn from Shropshire Community Health NHS Trust's policy framework, a useful quality improvement guide.
Right, and Stat Pearl's overview of QI methods, some research on stakeholder involvement in health policy.
And even a piece explaining clinical governance.
So our mission today is basically to extract the essential information on how healthcare organizations get evaluated and accredited.
Uncover maybe some surprising insights and bring some clarity to what can feel like a complex topic without, overwhelming you.
Okay, so let's unpack this. Kicking things off with ISQA. What exactly is their role on the international stage of healthcare accreditation?
Well, ISQA, that's the International Society for Quality in Healthcare. They're pretty key. They develop these international principles that act as a benchmark.
A benchmark for whom exactly?
For the organizations that themselves assess and accredit health and social care standards. So think accreditation bodies, certification bodies, inspection groups, the ones setting standards within healthcare.
Ah, okay. So ISQA is setting the standards for the standard setters in a way.
You could definitely see it like that. Their ISQA international principles are really aimed at making sure that if there are complaints about these external evaluation organizations, that those complaints are dealt with promptly, fairly, and, effectively.
And you mentioned, this is really interesting, these ISQA principles, they aren't just static, are they? They've been updated recently.
Yeah.
What are the big changes there?
That's right. They evolve. The recent updates have sort of streamlined the principles, putting a stronger focus on really important areas like how organizations manage risk and how they resolve ethical dilemmas. And a pretty significant change is that ISQA now requires the organizations they accredit to have transparent, published processes for how they develop their own standards.
Right. That makes sense. Transparency is key. And the order of the principles even changed, didn't it?
Yes, exactly. The new order is designed to reflect a more logical flow. It starts with standards development, then standards measurement, then organizational role, planning and performance, then safety and risk, patient or service user focus, and finally, quality performance.
So it builds up.
Yeah, the sequence really emphasizes a holistic view of quality.
It sounds like ISQA has a pretty wide reach then. What exactly do they accredit? Is it just the organizations?
It's quite broad, actually. They accredit the external evaluation organizations themselves, yes.
Yeah.
But they also accredit the specific health and social care standards that those organizations develop.
Ah, okay.
And importantly, they also accredit the training programs for the surveyors and assessors, the people actually doing the evaluations, making sure they're competent.
Got it. So if an organization wants to get that ISQA stamp of approval, what's involved? What's the process look like?
Well, the journey to ISQA accreditation has several key steps. It usually begins with the organization doing a pretty thorough self-assessment.
Right.
Then ISQA selects and trains the surveyors and the members for what they call a validation panel. They provide a detailed timeline, a critical path for the survey itself.
And then the survey happens.
Yes, the on-site survey takes place. And interestingly, if any part of the assessment gets a low rating, like a 1 or a 2, the organization actually has to conduct a risk assessment.
To figure out the impact of that low rating.
Exactly. To understand the potential impact. It makes perfect sense, really.
Yeah, it does. What happens after the survey's done?
After the survey, there's a technical review of all the findings. The organization might need to submit some additional documentation.
Okay.
Then the validation panel reviews everything and makes a recommendation to ISQA. but the final decision on granting accreditation rests with the ISQA Board Accreditation Committee.
It's interesting that ISQA itself has a process for creating its own principles. How did they go about reviewing and updating them? Did they follow their own advice?
Yes, they did. Following their own principles for developing standards, ISQA made sure to involve all their stakeholders in the review process.
So who did that include?
That included the organizations they accredit, the surveyors doing the assessments, and other experts within ISQA itself, really trying to get broad input.
And what about the research behind these principles? You mentioned something quite surprising about that earlier.
Yes, well, they did a literature review, looking for best practices in developing and implementing accreditation standards specifically for healthcare. Surprisingly, this review found, and I quote, a dearth of relevant research in this very specific area.
Wow, really?
Yeah. What's fascinating is that it really highlights the unique kind of specialized knowledge that exists within ISQA and the broader field of healthcare accreditation itself. It's not something you just find easily in academic papers, it seems.
That is a surprising nugget. Okay, let's switch gears now. Let's talk about NABH, the National Accreditation Board for Hospitals and Healthcare Providers. We've got their standards for care homes here. What's the main goal of NABH in this particular sector?
Right, so NABH's accreditation standards for care homes are primarily designed to, guide these facilities in providing and, importantly, continuously improving the quality of care and services for their residents.
So it gives them a framework.
Exactly, a framework for looking at all the essential functions within that care home environment.
So it's definitely more than just getting a certificate to hang on the wall then.
Oh, absolutely.
Yeah.
It gives care homes a real opportunity to understand the expectations for compliance and the really vital safety and regulatory requirements they need to meet.
And who does this apply to? Just traditional care homes?
It's pretty broad, actually. It applies to traditional care homes, senior living facilities, assisted living, transition living facilities, and even palliative care facilities.
Okay. The NABH documents often mention interpretations of the standards. What are those, and how do they actually help the care homes in practice?
The interpretations are really crucial. They provide guidance on how a care home can actually meet the requirements of a specific part of a standard. They often suggest practical ways of doing things, methodologies.
So they give examples?
Sort of, yeah. And importantly, they clarify which aspects are mandatory. You'll see words like shall or will. And then which are recommended or desirable, using words like can or could.
So the shall or will are the non-negotiables.
Exactly. Think of those as the absolute must-dos for safety and quality.
That sounds really practical. It's not just stating what's required, but giving some direction on how to achieve it. NABH also seems to stress the importance of documentation created by the care home staff themselves, right?
Yes, exactly. NABH really encourages care homes to develop clear, straightforward documentation that's actually used and understood by the staff performing the tasks.
Rather than generic templates?
Precisely. The goal is to reduce the reliance on maybe externally created documents that might not truly reflect the day-to-day operations or the specific context of that care home. It makes the documentation much more relevant and, frankly, easier to implement.
Makes sense. What are some of the key things NABH looks for in that documentation? Is there a checklist?
There are definitely key details. They specify things like the date the document was created, when it was approved, when it was last reviewed, potentially even an expiry date.
Okay.
It should also clearly show who was responsible for creating it, who approved it, who authorized changes. And little things like page numbers, maybe unique document control number. Often this is all found in a control box on the document itself.
Right, for version control and tracking. Now, how does NABH actually evaluate a care home's compliance? How does the scoring work?
They use a scoring system. The average score for each chapter of standards needs to be at least 4.
Okay, a minimum average.
Yes. And additionally, if any specific requirement within a standard gets a score of 3 or below, the care home must develop and implement an action plan with clear timelines for improvement.
So it triggers a response.
Exactly. And overall compliance is judged by looking at requirements classified as core, commitment, and achievement level. A key benchmark is hitting 80% compliance for those core and commitment level requirements.
So it's not just pass-fail, it's tiered.
Right. It demands continuous improvement. You need action plans, even for slightly lower scores. It highlights a proactive approach, not just a one-time check.
Leadership clearly plays a huge role in all of this. What specific responsibilities does NABH emphasize for leadership in a care home?
Oh, leadership is absolutely central. The leader is accountable for the day-to-day running of the care home, yes, but crucially for making sure it complies with all relevant laws, regulations, official notifications.
Like fire safety?
Exactly, essential areas like fire safety regulations, local building codes, things like that.
Facility management and safety, the FMS standards, seem like a big focus too. What do those cover specifically for care homes?
Yeah, the FMS standards are critical. They cover several areas. Having systems for a safe and secure environment, making sure the facility operates efficiently and responsibly, prioritizing the safety of residents, staff, and visitors.
And practical things.
Yes, having a plan for facility and engineering support, utility systems, and importantly, detailed plans for dealing with emergencies, both fire and non-fire related.
Can you give us some examples of the specific facility requirements NABH outlines, like physical things?
Sure. Care homes need adequate space for their services, with enough space per resident. The living environment must be safe, comfortable, the home's name and address clearly visible.
Basic stuff, but important.
Very. Separate office and reception areas for privacy. Accessibility is key too. Standards for staircases, bathing facilities for residents with disabilities, and regular safety rounds are mandated.
And they have to document those.
Absolutely. Documented inspections and any identified risks must lead to documented corrective actions. It's all about the follow-through.
Emergency preparedness is obviously critical in care homes, especially with vulnerable residents. What specific aspects does NABH emphasize there?
Yeah, they place a strong emphasis on effectively managing emergencies and also outbreaks of illness. This includes having measures for a safe environment, specifically for more vulnerable residents.
And end-of-life care.
That's also a significant focus, providing compassionate, respectful end-of-life care. Plus, robust systems to prevent and control healthcare-associated infections that falls under their HHIC standards.
Infection control is so vital. What are some tangible requirements there? Like, what do they actually have to do?
Specific requirements include things like mandatory training on hand hygiene for staff and residents, plus easily accessible hand-washing facilities.
Makes sense.
Also, separate areas for drying clothes to prevent cross-contamination and keeping toilets and bathrooms well-maintained with an adequate water supply. Basic, but critical.
Given the nature of care homes, having strong links to the broader healthcare system seems vital. What does NABH mandate regarding medical support?
Absolutely. NABH mandates formal agreements, tie-ups with local GPs, physicians, or hospitals for medical emergencies.
Okay.
They also need access to basic ambulance services, either provided directly or through an external provider. There must be clear written guidance on arranging patient transport, who's responsible, who makes the call.
And records.
Defined emergency protocols, diligently maintain medical records, and access to mental health support for residents are all required too.
What about feedback and complaints? How does NABH address listening to residents and their families? Seems important.
Very important. NABH stresses the process must be fair and transparent. Care homes need a written procedure for reporting, handling, and responding to complaints and feedback about services and the facility.
How is that made visible?
The name and phone number of a contact person for complaints must be clearly displayed, usually at reception. And importantly, all complaints and feedback have to be documented and monitored by management within defined timeframes.
And residents involved?
Yes, residents should be involved in discussions and informed about the outcomes. It closes the loop.
Okay, finally for care homes, let's touch on the human element. What are NABH's key standards for human resource management, or HRM?
Right. HRM standards cover several critical areas, determining the right number of staff and the necessary skills mix for safe care.
Staffing ratios.
Essentially, yes. Recruitment processes should be uniform, standardized. New staff need thorough orientation to the environment and their specific duties.
Performance reviews.
A systematic, structured appraisal system is required for staff development. The organization also needs to promote staff well-being, both physical and mental.
And qualifications.
Crucially, for healthcare professionals, ensuring they have the necessary credentials and a defined scope of practice is essential. Verifying qualifications and experience is mandatory.
That gives us a really solid overview of the care home standards. Now let's pivot to hospitals. NABH released its 6th edition of Hospital Accreditation Standards, effective January 2025. What are some overarching goals of this latest edition?
Well, the 6th edition builds on previous versions, definitely incorporating feedback from providers and experts. The main goals continue to be ensuring hospitals adhere to the highest levels of quality, safety, and patient-centered care.
But reflecting changes.
Exactly, reflecting the evolving healthcare landscape and increased awareness among patients about their rights and expectations.
What's the basic structure of these hospital standards? How are they organized? Is it similar to the care home ones?
Broadly similar in structure, they're organized into chapters, each focusing on a key aspect of hospital operations. Key chapters include responsibilities of management, ROM, facility management and safety, FMS, human resource management, HRM, and information management system, IMS.
And how is each chapter laid out?
Each chapter starts with an intent outlining the broad requirements. Then a summary of standards lists all the specific standards in that chapter. Then the standards and their specific requirements, called objective elements, are explained in detail, and each chapter wraps up with references.
Documentation seems to be a recurring theme everywhere. What types of documents does NABH emphasize for hospitals? Is it just SOPs?
For hospitals, NABH emphasizes comprehensive system documentation. That includes operational docs and quality system docs. SOPs, standard operating procedures, are key, giving detailed instructions.
Anything else?
Yes, detailed work instructions, too, for step-by-step guidance on specific tasks, including the physical execution. And manuals are another important category-controlled documents used across departments.
What specific information should hospitals include in their process and procedure documentation according to NABH?
They outline several essential elements. Every document needs a clear title. Its purpose stated. It should define the start and end points of the process, give a clear step-by-step procedure.
Standard stuff, yeah.
List related records documents. Include authorization details, signatures, job titles, issue version number, issue date, all the controls.
Maintaining accreditation isn't a one-off. What are the criteria for continuing NABH accreditation for hospitals?
Right, it's ongoing. To maintain accreditation, hospitals must achieve an overall compliance rate of at least 80% during surveillance and reaccreditation assessments.
Okay, 80%.
And meet specific rules during those assessments. Importantly, the scoring gets adjusted. If certain requirements don't apply to a hospital's specific services, they exclude those from the calculation.
Fair enough. We talked about facility management and safety, FMS, for care homes. How did the FMS standards compare for hospitals in this 6th edition? Any big changes?
Interestingly, NABH indicates that for hospitals, the FMS standards themselves have largely remained the same from the 5th to the 6th edition.
Oh.
However, there have been some changes in how certain elements are interpreted. That suggests maybe a greater focus on how they're actually put into practice, the implementation.
The 6th edition also includes a glossary. Are there any definitions in there that really stand out as important for understanding the standards?
Yeah, the glossary is really helpful for clarity. Terms like adverse drug reaction, the different types of consent, implied, expressed, informed, handoff, handover, patient-centered care, patient engagement, patient record, policies and procedures, protocol, quality, qualified standards, they're all defined. Ensures everyone's speaking the same language.
Okay, let's dive into some of the clinical areas covered. What do the access, assessment of patients, and continuity of care AAC standards address? That sounds fundamental.
It really is. The AAC standards focus on making sure patients can actually get the care they need. This means having clearly defined clinical services provided by qualified staff with a defined scope for each service.
And making that visible?
Yes, these services should be clearly displayed. The standards also cover written guidelines for registration, admission, how initial and ongoing patient assessments are done.
Like reassessments.
Exactly. And providing necessary lab and imaging services, ensuring smooth continuity of care throughout the patient's entire journey is really the central theme here.
And what about the care of patients' COPS standards? What's the focus there?
COPS standards emphasize delivering safe clinical procedures, safe blood transfusions, and systematic care in places like intensive care and high-dependency units.
Okay.
They also address safety in obstetric and pediatric services, procedural sedation, and anesthesia. Nursing care is a big part, requiring adherence to written guidelines, clinical protocols, and appropriate patient care assignments.
What about emergencies within the hospital?
Yes, COPS standards also mandate protocols for things like cardiopulmonary resuscitation and implementing corrective and preventive actions after any adverse events, learning from mistakes.
End-of-life care came up for care homes. Does NABH address this in the hospital standards too?
Yes, definitely. The hospital standards also emphasize providing compassionate, respectful end-of-life care. This requires a team approach, multi-professional. while respecting legal requirements and the individual's and family's needs.
So, symptom management.
Yes, providing treatment to relieve symptoms and addressing the unique needs of patients nearing the end of life.
Medication safety is always a huge concern in hospitals. What do the medication management and medication safety MOM standards cover? Sounds critical.
They are very critical and comprehensive. MOM standards cover safe, rational prescribing practices, ensuring prescription requirements are followed, thoroughly checking for allergies and past adverse reactions.
Support for doctors.
Yes, having systems to help clinicians make safe prescribing choices. They also define how meds should be stored, labeled, how high-risk medications are managed.
Like look-alike, sound-alike drugs.
Exactly. Separate storage, considering look-alike, sound-alike issues. Also defining and uniformly storing emergency medications, ensuring they're promptly restocked after use.
Making sure patients know their rights is paramount. What are the patient rights and education PRE standards all about?
PRE standards focus squarely on making sure patients are informed about their rights and responsibilities during care, and actively promoting and protecting those rights.
What if rights are violated?
Hospitals must have mechanisms for patients to report violations, and these reports must be tracked, analyzed, and addressed by the hospital leadership. There has to be accountability.
Infection prevention and control has its own chapter, right? The IPC standards. What's the scope there for hospitals?
Yes, IPC standards mandate a documented program across the entire hospital. The program's aim is clear: reduce the risks of infections that patients, visitors, and healthcare workers might acquire while at the hospital. Hospital-acquired infections.
Got it. Finally, in this section, what are the patient safety and quality improvement PSQ standards focused on?
PSQ standards emphasize using various tools, analytical, managerial, statistical, for continuous quality improvement and patient safety.
Like data.
Yes, capturing data, like patient-reported outcome measures, and establishing a strong system for clinical audits with clear guidelines and active staff participation, always looking to improve.
We touched on responsibilities of management, ROM, and facility management and safety, FMS, earlier. What are the key focuses of the Human Resource Management, HRM, and Information Management System, IMS chapters for hospitals? They sound like foundational elements.
They really are. HRM standards in hospitals cover ensuring staff are qualified and competent for their roles, using clear job descriptions, doing regular performance reviews.
Training.
Yes, providing ongoing training, especially on safety and quality, making sure staff know incident reporting procedures, and thoroughly verifying credentials and privileges for medical staff.
And the Information Management System, IMS medical records.
Exactly. IMS focuses on maintaining complete, accurate medical records, with clearly defined content, a chronological account of care, ensuring only authorized staff make entries.
Signed, dated, timed.
Yes. Signed, dated, timed, identifiable author, and using only approved abbreviations. Accuracy and accountability in records are key.
The 6th edition also mentions key performance indicators, or KPIs. What's their role in this whole accreditation process? Are they just for reporting?
No, KPIs are essential for actually driving improvement. The standards define specific KPIs with standardized definitions, including numerators and denominators, to ensure consistent data collection and analysis.
So the data is comparable.
Right. And that data then informs efforts to improve quality and safety. Examples include tracking rates of adverse drug reactions, medication errors, adherence to wrong-site surgery prevention protocol.
Hospital infections again.
Yes, rates of hospital-acquired infections like UTI, VAP, CLAM-BS. Also, waiting times for diagnostics, patient falls, hypoglycemic events, post-op eye infections, COPD action plans at discharge, sepsis management bundle adherence. Lots of specific measures.
Policies and procedures are clearly foundational to meeting all these standards. vComply's overview highlights some key reasons why they're so important. Can you elaborate on that?
Yeah, vComply makes a great point. Policies and procedures ensure care is delivered consistently across departments, across shifts, by different staff members.
Avoids variation.
Exactly. That consistency is vital to prevent variations that could negatively impact patient outcomes. Plus, well-defined policies are essential for meeting legal and regulatory requirements. Think HIPAA for patient privacy, OSHA for workplace safety. Helps avoid fines, legal trouble.
Alameda Health System's policy approval workflow gives us a real-world peek at how these policies get developed and reviewed. What does their process look like? Sounds complex.
It is structured. It often starts with review within the relevant department, then goes to specific committees like Pharmacy and Therapeutics, Clinical Practice Committee, Medical Executive Committee.
Even the board sometimes.
In some cases, yeah, policies might need approval from the Board of Trustees. And their documentation for each policy includes review dates, who owns the policy, its purpose, any changes made, which committees reviewed it.
It's interesting how many of their specific policies, medication borrowing, disaster prep, really tie back to that core principle of patient safety we keep seeing.
Absolutely. It shows how these high-level standards translate into very practical, day-to-day operational guidelines.
They have a huge range of policies, don't they? Some very specific ones mentioned in the source.
Oh, definitely. Their policies cover a massive spectrum. General guidelines for epidemics, how to triage critical care resources, down to very specific things like pain assessment, restraints, hazard analysis,
residency programs, nurse advice lines,
of IV admixture, compounding, stroke center improvement, use of 300 BB drugs, financial assistance, resident supervision, and of course their emergency operations plan. It really demonstrates how accreditation standards ripple through every aspect of a hospital's function.
Let's focus on that emergency operations management plan for a moment. What's the key framework they use for preparedness and response?
Alameda's plan uses the Hospital Incident Command System, HICS. That's its main structure for preparing for and responding to emergencies.
And it connects outwards.
Yes, it helps them coordinate with community responders, the county EOC, city, fire, police, neighboring hospitals. It's designed to integrate.
What are the different phases of emergency management their plan addresses? Is it just the response?
No, it covers the whole cycle. Mitigation steps taken beforehand to reduce impact, like structural projects. Preparedness planning, training, drills, identifying resources, response actions during the event, and recovery restoring normal operations afterwards.
Communication is obviously critical during an emergency. What methods does their plan outline? How do they talk to people?
The plan details various methods. Externally, maybe public service announcements, website updates. Internally, it's a mix. Phones, cell phones, radios, pagers, email, overhead paging, runners, even fax.
Old school.
Yeah. And they use specific HICS forms too, like the Incident Communications Plan, Incident Message Form, to keep communication standardized during chaos.
Resource management must be a nightmare in an emergency. How does Alameda approach this in their plan?
It emphasizes careful management, identifying resources that could potentially be shared with other hospitals based on command team decisions. Biomedical engineering inventories, critical equipment. Materials management handles vendor contracts for supplies. It's all planned out.
What about staff roles? Does everyone just do their normal job?
No. The plan defines specific emergency responsibilities, often using job action sheets to outline roles within the EOP. The incident commander makes the final calls on maintaining essential services, communicated via the incident action plan.
Resident physician supervision is another specific policy they have. What are the different levels of supervision they define? Seems important for training hospitals.
Very important. Alameda defines 3 levels. Direct supervision, where the supervising doc is physically present. Indirect, with direct supervision immediately available if needed. And indirect, where the supervisor is available for prompt discussion, but maybe not right there.
And it outlines faculty responsibilities.
Yes, where the supervising faculty members are responsible for it, overseeing the residents.
It also addresses what happens if residents run into trouble, doesn't it? Performance issues.
Yes, the policy includes procedures for evaluation, probation, even suspension or termination. But importantly, it emphasizes due process warnings, hearings, fairness.
The policy on interdisciplinary team decision-making for incapacitated, unrepresented patients sounds ethically complex. What's the process they've established there?
It is complex. The policy sets out a clear process for making medical decisions when a patient lacks capacity and has no designated surrogate. First step is a diligent search for any surrogate or support network.
And informing the patient.
Yes, the patient is informed about their status and their right to seek judicial review. Then an interdisciplinary team, the treating docs, relevant specialists, considers treatment options. The ethics committee is available for consultation too.
How are decisions made?
Based on the patient's best interests, considering their known values if possible, prognosis, treatment options, potential burdens and benefits. It also allows the institution to decline care contrary to their policies for reasons of conscience, if communicated promptly.
Their staff recruitment policy seems standard, outlining the hiring process. Anything specific worth noting there?
It covers the whole process, requisition to hiring. A key aspect highlighted is the emphasis on background checks upon hire, and also later if there's reasonable cause. HR screens, Managers interview, department manager decides with HR. Pretty standard, but thorough.
They even have policies for super specific things like medication borrowing between their own pharmacies. What are the key requirements for that? Sounds like it could get complicated with drug programs like 340B.
It does need careful management. The policy sets procedures for their inpatient pharmacies, both 340B and non-340B, to borrow from each other. It has to be initiated by a pharmacist or tech.
And tracking.
Yes. The borrower needs the exact National Drug Code, NDC, from the lending pharmacy and must confirm they can order the same NDC from their supplier within 3 days, especially for non-340B borrowing. Tight controls.
Proper medication storage is crucial everywhere. What does their policy detail in that area? Temp logs, security.
Yes, all of that. Their policy outlines requirements for all med storage areas. Clean, secure, controlled access, regular temperature monitoring, specific temp ranges for fridges and freezers are defined, plus actions for deviations.
How are meds organized?
Generally alphabetical order. Handling of frozen meds is specified. And yes, twice daily temperature logs are required.
Disaster pharmacy preparedness, another specific plan. What does that cover? What happens to the pharmacy in a disaster?
This policy outlines procedures for pharmacy operations during internal or external disasters. Includes communication plans, lists of essential emergency meds, procedures for dispensing manually if electronic systems fail.
Labeling, supplies.
Yes, guidelines for labeling during a disaster, access to drug info resources, and how to secure extra supplies. Keeping the pharmacy running is critical.
They also have a policy for managing patient trust accounts. What's the gist of that? Seems like a fiduciary duty.
It is. The policy basically outlines procedures for managing money held in trust for patients, including how to submit and get approval for check requests to pay out those funds. Accountability for patient funds.
Infusion pumps are ubiquitous. Their policy on managing them must be vital for safety. What does it address? Programming errors.
Absolutely. Their policy covers safe, correct use, safety features, programming emphasizing their drug error reduction system, DERSIS, and medication library, MDL, to prevent errors.
And maintenance.
Yes. Cleaning, maintenance procedures, and importantly, the process for reporting any malfunctions, keeping those pumps safe and functional.
Obstetric analgesia and anesthesia, a sensitive area. What does their policy cover there? Consent, monitoring.
It addresses guidelines for pain management during labor and delivery. Includes requirements for informed consent, necessary patient monitoring, and specific procedures for different clinical situations, like placing a cervical circlage. Tailored guidelines.
For neonatal care, they have a policy on basic care and positive airway pressure, BCPAP. What are the key aspects? Setup, weaning.
This policy outlines procedures for providing basic care to newborns and using BCPAP. Includes equipment setup, necessary monitoring, and how to gradually wean infants off BCPAP when appropriate.
Compounding sterile products carries huge risks if not done right. What does Alameda's policy detail for this? Clean rooms, testing.
It details strict procedures for safe preparation in a clean room, protocols for traffic control, hand hygiene, gloving, equipment sanitation, reconstitution techniques, labeling.
And staff competency.
Yes. Mandatory training and evaluation of personnel, including fingertip testing and media fill tests to ensure their aseptic technique is perfect. Very high standards needed there.
Stroke care is time critical, often needing transfers. What do their stroke transfer guidelines specify? Timelines, criteria.
Their guidelines specify criteria for transferring stroke patients to other hospitals based on the stroke type and treatment eligibility, like for thrombectomy. They also include internal benchmarks, targets for how quickly head CT or MRI scans must be interpreted for stroke patients. Speed matters.
Finally, their physician practice office policy seems pretty straightforward. What's the main requirement? Just keeping addresses updated.
Essentially, yes.
Yeah.
It requires all medical staff to keep their current office addresses updated with the medical staff office. It's framed as a requirement for maintaining privileges, ultimately for patient care coordination and safety. Simple, but necessary.
We've seen how Alameda develops policies. Shropshire Community Health NHS Trust in the UK also has a structured approach, their policy approval and ratification framework. What are the key steps in their process? Is it similar?
It outlines a clear, multi-stage process. Starts with identifying the need for a policy, then drafting it. Importantly, the draft goes through consultation with relevant stakeholders.
Getting input.
Exactly. Then review by appropriate committees before final approval and official ratification, making it policy.
How often do they review their policies? Does stuff get outdated?
Their standard practice is review every 3 years, or sooner, if guidance or legislation changes. They also have a process for minor revisions outside the full framework if it doesn't affect core practices like updating a responsible person's name.
And a clarity.
Yes, they emphasize using clear, concise, unambiguous language in a standard template for all policies. Consistency again.
To continuously improve, organizations rely on quality improvement methods. Our sources include a QI guide and Stat Pearl's overview. What are some fundamental QI principles? Where do you even start?
The QI guide emphasizes a team-based approach, focused on a specific aim or goal, using regular data review and making changes through rapid cycles. The Plan, Do, Study Act, or PDSA, cycle is key here.
What's the model for improvement?
That provides a fundamental structure. It asks 3 questions. What are we trying to accomplish? How will we know if a change is an improvement? And what changes can we make that will result in improvement? Simple questions, powerful framework. Assembling a diverse QI team with a respected leader is also highlighted as crucial.
What are some of the key QI tools these sources mention, like the practical things teams use?
Several useful tools come up. Process mapping, or flowcharts to visualize and understand processes, fishbone diagrams for root cause analysis, figuring out why something happened.
Data tools.
Check sheets and Pareto charts for collecting data and prioritizing where to focus effort. Run charts track changes over time. Control charts help understand variation within a process. Is it stable or unpredictable? The QI guide even includes a template for a project charter to formalize the effort.
Stat Pearls also describes specific methodologies like Lean. What are some core Lean concepts or tools used in healthcare?
Lean focuses on continuous, rapid improvement via team efforts, often called Kaizen events. It uses tools like 5S for workplace organization sorting, setting in order, shining, standardizing, sustaining.
Efficiency focused.
Yes, and reducing waste. Also, just-in-time, JIT, for supply availability, Kanban systems for inventory management, and A3 reports as a visual problem-solving tool.
The PDSA cycle seems to pop up everywhere in QI. What's the essence of that cycle again? Plan, do.
Plan, do, study, act. Plan a change or test. Do it on a small scale, a pilot. Study the results, what happened, did it work? Then act based on what you learned. Adopt the change, adapt it, or abandon it. It's iterative learning by doing.
Why is all this focus on quality improvement so critical in healthcare? It sounds like a lot of work.
It is work, but as Stat Pearls highlights, errors and hazards are unfortunately a reality in healthcare. QI methods are clinically significant because they help reduce medical errors, improve patient safety.
Fix bottlenecks.
Exactly. Address process bottlenecks that cause delays in diagnosis or treatment. Ultimately, it leads to better patient outcomes and can even lower cost by reducing waste and rework.
Implementing health policies effectively isn't just about writing them down. It requires engaging stakeholders. A research paper we looked at gives lessons learned here. Why is stakeholder engagement so important? Who are stakeholders anyway?
Stakeholders are anyone with an interest. Patients, healthcare professionals, community groups, government agencies, payers. A wide range. Involving them is crucial to make sure health policies are relevant, inclusive, and actually work in the real world. Their diverse perspectives strengthen the policy.
Makes sense. What are some of the challenges in actually doing that engagement? It sounds easy, but probably isn't.
The paper identifies several hurdles. Power imbalances, some stakeholders having more clout than others, competing interests, different groups wanting different things, making consensus hard, and limited resources time. Funding can make full participation difficult for some groups.
Despite those challenges, what are some key lessons learned for successful collaboration? How do you make it work?
The research emphasizes identifying stakeholders early and proactively building trust in relationships. Tailoring engagement strategies to different groups one size doesn't fit all.
Communication.
Clear, consistent communication is essential. Fostering genuine shared decision-making, not just token consultation. And being committed to continuous learning, adapting based on feedback. The paper also highlights the key roles community organizations and patients themselves play in implementation.
Okay, finally, let's touch on clinical governance. One source defines it as a framework for accountability and continuous quality improvement. What are some of its key elements? Sounds overarching.
It is quite overarching. Clinical governance includes ensuring clinical practices are effective, evidence-based, following guidelines, supporting research and development, managing risks through incident reporting, near-miss analysis, root cause analysis, risk registers.
Audits, training.
Yes, performing audits to check practice against standards, providing ongoing education and training for staff, and actively involving patients and the public. It also covers understanding incident classifications, near misses, significant events, never events, those really serious preventable ones.
Duty of candor.
Yes. The UK's duty of candor, being open and honest with patients when harm occurs, is a key part of that risk management and patient involvement aspect.
So tying it back to policies, why is it so important for organizations to regularly review their policies and procedures, as PowerDMS highlights? Why not just write them and leave them?
Because things change. Regular review is essential to make sure policies stay current, accurate, legally compliant, and reflect the latest best practices. Healthcare evolves constantly. Policies need to be living documents, not dusty binders on a shelf.
Wow. Okay. We have covered a tremendous amount of ground in this deep dive. Let's try and quickly summarize some of the key takeaways from all of this.
Absolutely. I think the big picture is that healthcare accreditation is this really comprehensive, multifaceted process. You've got international principles from ISQA setting the bar and national standards like NABH, tailoring it for specific settings like care homes and hospitals.
And the common threads.
The consistent focus is clearly on quality, safety, patient-centeredness. Also, the absolute necessity of robust documentation, the drive for continuous improvement using QI methods, and the critical role of clear current policies and procedures.
And those broader concepts.
Right. Stakeholder engagement and strong clinical governance frameworks are vital for actually making these standards work and stick in practice.
What was that surprising fact again that really stood out to you during our prep?
For me, it was definitely that finding from the ISQA review, the dearth of relevant research, specifically on developing and implementing healthcare accreditation standards. It just underscores how much specialized practical expertise exists within this field, maybe not always captured in traditional research.
Yeah, that was interesting. For me, the aha moment, I think, was really internalizing that accreditation isn't just a checklist exercise.
Right.
It's a dynamic framework. It requires ongoing assessment, proactive risk management, really digging into incidents when they happen, and a genuine commitment to learning and improving, at all levels of an organization.
Precisely. And for you, the listener, why does all this matter? Well, whether you're prepping for a meeting, just curious about healthcare quality, or want to be an informed patient or family member, understanding these accreditation principles gives you valuable insight into the structures and processes designed, hopefully, to ensure safe and effective healthcare for everyone.
So thinking about those NABH core elements, for example.
Right. If you're following along, think of core elements as those absolute non-negotiables, the fundamental safety pillars.
Yeah.
Commitment level items are where the organization needs to show a clear plan and dedication towards best practices. Understanding that hierarchy is key.
Okay, finally, here's a provocative thought for you, the listener, to chew on. Consider how these principles we've discussed, quality improvement, stakeholder engagement, accountability frameworks, all within healthcare accreditation, how could they be applied to other complex systems?
Like in education, or finance, or even government.
Exactly. Think about organizations or systems you're familiar with. What might be the key challenges and the opportunities for ensuring quality and accountability in those different contexts? Something to mull over.
Definitely food for thought.
Thanks for joining us on this deep dive.